Postpartum hemorrhages, a serious but rare condition, occurs in 1 in 5 women who have a baby. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, Executive Speechwriter with AHA. In this Members in Action podcast featuring maternal and child health efforts, Aisha Syeda, Program Manager at the AHA, is joined by maternal health experts from the Children's Hospital of San Antonio. Aisha is speaking with Chris Daskovich, Chief Executive Officer at the Children's Hospital of San Antonio and Senior Vice President of Maternal Services at Christus Health, and Dr. Shad Deering, who is the Associate Dean and Acting Chair of OBGYN at Baylor College of Medicine at the Children's Hospital of San Antonio, and the System Medical Director for the Christus Simulation Institute. Joining them is Dr. James Hill. Dr. Hill is a maternal fetal medicine specialist at the Children's Hospital of San Antonio and Professor and Director of the Maternal Fetal Medicine Division for the Department of Obstetrics and Gynecology at Baylor College of Medicine. Together, these experts will highlight an obstetric simulation program called Practicing for Patients. This national program was created by the American College of Obstetricians and Gynecologists Simulation Working Group in collaboration with the Council on Patient Safety in Women's Healthcare. It's being implemented across the entire state of Texas through the Texas AIM Collaborative. This national program is designed to help hospitals, such as the Children's Hospital of San Antonio, conduct simulation drills on their labor and delivery units to provide better care to women who experience a postpartum hemorrhage or hypertensive emergency during pregnancy.
Thank you, Tom. And thank you, Chris, Dr. Deering, and Dr. Hill for speaking with me today. To start us off, Chris, can you share a little bit about why improving maternal health outcomes is important for the Children's Hospital of San Antonio?
Well, thank you, Aisha. Just as a brief introduction to who we are, Christus Health is an international not-for-profit Catholic health system with multiple care settings in 32 urban and rural hospitals across Texas, Louisiana, Arkansas, and New Mexico. We're also the largest not-for-profit in Latin America with 14 hospitals, and we have more than 45,000 associates and 15,000 physicians across our system. We deliver about 20,000 babies each year in the United States. So improving maternal care and decreasing maternal mortality and morbidity has been a huge focus for us the past several years. Now, with the U.S. having the highest maternal death rate among the world's developed nations, and with both Texas and Louisiana, where we have facilities, unfortunately being in the top 4 states with the worst stats in maternal mortality and morbidity, we knew that as a system, we had to focus here immediately. We are very proud of what Texas has done over the past several years to elevate the state and improve our maternal and neonatal outcomes. The state recently developed a perinatal steering committee that then assigned and created both a neonatal designation process and a maternal levels of care designation process. Those have been in effect for the past couple of years, and everyone has been preparing for the process. The state really put forth incredible efforts. They have, and we've had amazing partnerships with the Department of Health and Human Services, Texas Hospital Association, Texas AIM, ACOG, even the American Hospital Association Maternal Child Health Committee. And it's really been an amazing collaboration. You'll hear about that today from Dr. Deering and Dr. Hill, but 98% of all Texas hospitals that deliver babies have participated in Texas AIM, which I think is just incredible, where you're seeing a state with one of the worst outcomes now has been doing some of the most work in order to improve in this area. The other piece of this is that Louisiana is actually quickly following in Texas footsteps, and they are developing their own levels of care designation modeled after Texas as well. At Christus, we have been doing a couple of things at the system. We developed 3 years ago when I arrived, we developed a perinatal executive steering committee that has representation in obstetrics, neonatology, maternal fetal medicine from every Christus hospital that delivers babies in our system. The team has focused on best practices, standardization of policies and procedures. We do a lot of sharing in these best practices, a lot of practicing. You're going to hear today about some of those efforts. And we've also been able to leverage a lot of our clinical experts here at the Children's Hospital of San Antonio. We provide medical leadership and consultation in maternal fetal medicine, in neonatology and obstetrics, and we partner with our colleagues at Baylor College of Medicine across all of our ministries. So it really has been a change and a system perspective that Christus has brought forth in order to address and improve in our maternal outcomes. So I'm going to turn it over to Dr. Deering and Dr. Hill because they're going to talk about how we've been collaborating in our teaching and training efforts that have been led out of the Children's Hospital of San Antonio, and we've had some really wonderful participation and outcomes.
Thank you, Chris, for providing that context. Dr. Deering and Dr. Hill, can you share information about the hospital's OB simulation program and what's the impetus of that and what you hope to accomplish through that?
Yeah, absolutely. And thanks so much for the opportunity to kind of share this. We're really excited about it. I'm going to talk a little bit about the program, and Dr. Hill's going to talk a bit about some of the real world implementation things that we've seen after. So the first thing I want to start with, we're talking about a program called Practicing for Patients. And it is being put out throughout Texas through AIM, which is the Alliance for Innovation on Maternal Health. The genesis of this program is, and the basic concept is, we want every size hospital, regardless of what their resources are, if they do deliveries, we want them to be able to practice at their hospital. There's a lot of evidence out there for simulation training for OB emergencies with regards to how important it is and that it can improve maternal and fetal outcomes, which is great. And, we love the opportunity to do simulation and practice, and we can do it in a simulation lab, but there's something that's just so much more powerful about doing it at your hospital, because there's just a lot of things that you don't get in the lab. You get to practice with the people you actually take care of a patient with. You get to see how your systems work. You get to know how long it takes to get labs or to get blood products or how the phone calls go out. So it's really one of those things that it's critically important to practice for these emergencies where you actually take care of the patients. So what happened is a couple years ago, the American College of OBGYN has a simulation working group that we're a part of, and we pitched the idea to the Council for Patient Safety and Women's Healthcare, who works with AIM. And we said, you have these wonderful bundles that are coming out from AIM looking to improve maternal outcomes, and we would love to help be the implementation part of that. And so through that collaboration, and again, the Patient Safety Council is an amazing multidisciplinary group. It has physicians, nursing, nurse midwives, family medicine, pediatrics, anesthesia, industry, others. It's a great group that comes together. So these recommendations for not only care with regards to the bundles, but also in implementation, they're not just coming out from one organization or another. They really are something that's taking a holistic view of it. So we went and talked to them and said, we would love to partner with you and to create a program so that any size hospital anywhere in the country could run drills at their institution. I think part of the recognition that these are required is that the Joint Commission came out with recommendations and requirements now that drills need to be run at the hospitals, and that started in January of this year. One of the barriers to implementing this is we have a lot of people who they see that there's a requirement, but in terms of knowing how to run a simulation, what equipment to use, how to debrief it, those are things that they take a lot of bandwidth, and we saw just a lot of people continuing to create things over and over. And we wanted to come up with something that would be a free resource that any size hospital could take, and they could really go and implement this program. So we put this together, and it came out. It's free. It's online on the council's website and through ACOG. And then we were having a discussion. I was actually at a meeting with Dr. Lisa Ollier, who was at the time the president of the American College of OBGYN, and she connected us with Texas AIM. Like you heard Chris talking about, Texas AIM is in 98% of the hospitals in Texas that have signed on to do this, and they were in the middle of working on postpartum hemorrhage and using the AIM bundle. So our discussion with them was, let's see if we can use this program, which was created specifically to run drills for hemorrhage. And let's see if we can do that throughout Texas. So in about 6 weeks' time, we worked into their learning sessions and we created a program where we would go and actually run these courses. So we did implementation courses to take all of the materials that have already been created that are free and teach these to hospitals across the state. We wound up going to 5 different locations and running full-day courses. So in terms of what's included in the program, this is a comprehensive program. It has an instruction manual. It has PowerPoints that have already been made, so you can go and brief your leadership on here's the program, here's why we need to do it, here's what's required to do it. We have simulator options that are available. I will tell you that this program is not tied to any specific simulator. We purposely did that because we want people to be able to use what they have. We standardized simulations. So we have for the initial rollout, it was postpartum hemorrhage. We had different scenarios. We had debriefing forums and how to go through and give feedback, because that really is one of the most challenging parts of it. And then we even filmed video examples of when you run the simulation, here's what it should look like. And again, these are all free and available online. We went to these 5 different locations throughout Texas, and we wound up training over 120 hospitals, over 300 providers. And then Texas AIM, through resources from the state, has purchased a simulator for every one of the hospitals that participated, and they have mailed those out. So not only did they get to come and practice, and they got to do hands-on and learn how to run the simulations, but we gave them the resources so they could take them, go back to their institutions, practice it, and then we even sent them the equipment to do it. I cannot say enough good things about the organization and the support and just really the commitment that the team in Texas has had with regards to the Texas AIM and that group, all of the faculty, everyone that was involved. It really was an amazing effort to see. And actually, Dr. Hill, I'll turn it over to you, because you not only got to help, but you also got to see some of the hands-on stuff at your own hospital right after that.
Yeah, thank you, Dr. Deering. I agree that it's been a wonderful implementation of the training that you spoke of. And as part of that training that Dr. Deering spoke of, what we knew was that we needed to get these tools and resources that had been identified back to the frontline staff at our hospitals. So what we first did was we selected what was called an implementation team or a trainer team. And that included a lot of key folks, for instance, myself as the maternal medical director, labor and delivery, my nurse program manager of labor and delivery. And then we identified a physician leader or a champion, one nurse leader who was also a champion, and then a nurse educator. And we asked them to participate in that implementation course that you spoke of. It was a 2-day training course. As you mentioned, they gave them an opportunity to learn how to run simulations, how to do debriefings, and then how to take that back to our staff at our hospitals. The other thing that we tried to do was we knew that based on some of the requirements from Joint Commission and some of the things that were being designated or asked by us by the state of Texas, we wanted to at least do these drills on an annual basis to kind of determine any system issues as part of an ongoing quality improvement effort. And we wanted these drills to include representation from each discipline that we identified in our hospital hemorrhage response procedure, and to include a team debriefing after the drill. In terms of the disciplines, we wanted someone from anesthesia, we wanted pharmacy to be there, we wanted blood bank to be there, we wanted participation from the intensive care units, the emergency room, respiratory therapy, nurses, physicians, and even residents, family medicine residents, as well as OB residents to be a part of the drill. And so one of the first things we had to do was, in order to deal with the time constraints, we had to pick a consistent time and a consistent date each month to do these drills. And then we had to start with just one scenario. We started with OB hemorrhage because we knew that our team had been part of that training. And so these simulations have basically allowed us to sort of hardwire best practices into our daily care. And this is in line with what Texas is trying to do to reduce maternal morbidity and mortality. In fact, as you know, as part of Texas' fight to try and reduce mortality and morbidity, Texas law now requires all hospitals to provide, or any hospital that provides maternity services, to receive a maternal level of care designation. That is level 1 through level 4, where level 4 facilities provide the most comprehensive care for those pregnant and postpartum patients, from low risk conditions to the most complex medical, surgical, or obstetrical condition. And so in regards to these team-based drills and educations, how does this all relate to maternal levels of care? Well, let me just briefly talk about the maternal levels of care from Texas rules. Relevance here is that we know that team-based drills and simulations improve outcome for a number of different reasons. And so with the maternal levels of care designation, it's a little separate from Texas AIM, but obviously there are a number of different components of Texas AIM and simulations that can be used with the maternal levels of designation. So first of all, it applies to all different levels of hospital care. That is level 1, level 2, level 3, and level 4. And the most direct rule in the maternal levels of designation from the state is in regards to perinatal education, where that rule specifically addresses or discusses the importance of coordination of staff supervision and education for high-risk events. And then the next piece also applies to all levels from level 1 through level 4, is that the medical staff is supposed to participate in ongoing staff and team-based education and training. So for me personally, I can't think of a better way to do that than through simulation and team-based drills. And it was important, as part of the requirements for the state, is to show physician, nurses, participation, and then document that people have not only participated, but they have the competency for that particular high-risk event. So every faculty member has to participate in it. And not only are the faculty members and the staff required to participate in it, but the Texas rule also requires that the medical director, the maternal medical director, which in my case happens to be me for labor and delivery, and the maternal program manager, which is usually a nurse, also has to participate in team-based education and training. So I think simulation, team-based education training is an excellent way to establish that not only are you doing what you're supposed to be doing, but it's an excellent way to practice and educate your team and then ensure that you're meeting the requirements for the maternal levels of designation.
Thank you, Dr. Hill. All that information was so good to hear, because I love that it's integrated with team-based care, it's integrated with collaboration across different professionals, and then, of course, getting those AIM bundles as part of the simulation program. Can you share some of the outcomes or impacts you've seen in this program, especially in your hospital?
Yeah, that's a good question. One of the things that, running these simulations has done is allowed us to see where our gaps are and then see how we can improve and provide better, not only education, but the type of care that Texas AIM sort of asked us to do, as well as the state in preparation for the maternal levels of care. So we looked at it in terms of 4 big categories. One was readiness. Are we providing the things? Do we have the supplies to take care of these women? And so we created, before this all started, we only had 1 hemorrhage cart for the entire labor and delivery unit. We've increased that cart to multiple carts throughout the postpartum unit, our antepartum unit, and even in our labor and delivery unit, and made sure that those carts have the right supplies. There are checklists that we created. We have instruction cards for placing these balloons, tamponade balloons that we can place inside the uterus. We make sure we've got IV tubing and so forth and so on. And then the other thing that the simulations has taught us is how to make sure we have immediate access to the medications that we need. And then does everyone know who to call and how to get a hold of support services such as blood bank and the G1 oncologists that we may need? And then we've gone back and looked at our massive transfusion protocol. And then the other key piece is assessing the patient's hemorrhage risk. That can be done prenatally, that can be done on admission, and it should be done throughout the time that that patient's admitted. And then the other key thing is we've moved away from the estimated blood loss to now we sort of standardize quantitatively measuring blood loss. And that's been a big change and a culture change for a lot of physicians. And then we looked at a sort of a standardized approach to what we call a stage-based obstetrical hemorrhage with checklists. And then the last thing we looked at based on the simulations is a support program for those patients who've undergone an OB hemorrhage, but not only a support program for the patients, but also for the families, and then those staff members to include the nurses and physicians who were part of that care, ensure that we're supporting them and providing them with their needs. Let me give you a real life example. And this happened not too long ago, but there was a woman who came to our hospital in her early 40s. She was pregnant for the third time. She got admitted to labor and delivery, and she came in for a routine repeat cesarean delivery that goes well. There's no complications. She then gets admitted to the recovery room after her cesarean delivery. She's doing well there, and they shortly thereafter transition her back to her postpartum room. So now it's been 3 hours since her delivery, and all of a sudden she starts to have excessive vaginal bleeding. And she's starting to pass these large-sized clots. The nurse comes into her room after being summoned and quickly notices that she's having a postpartum hemorrhage and contacts a physician to come in and evaluate her. If you take this back a year ago, before we began doing simulations, this is what that phone call would sound like to the physician. Dr. Jones, I have one of your patients in room 1106, and she's bleeding pretty heavily. Can you come to the hospital to assess her? Well, fast forward to today, after we've been doing these simulations and team-based drills for a while, here's what that phone call would sound like. Dr. Jones, this is Mary in room 1106. I'm taking care of Mrs. Such and such, who is having a postpartum hemorrhage with uterine atony. She is a 42-year-old gravida 3, now period 3, status post repeat cesarean delivery 3 hours ago. Where her quantitative blood loss was 585 milliliters, but now her total quantitative blood loss is 1257 milliliters, and her blood pressure is 95/60, and her heart rate's 120. I have given her oxytocin. I've called for methogen. I urgently need you to come into the hospital now. So that is what we call a brief summary of her situation, her background, an assessment of the situation, and then a recommendation by the nurse in contacting the physician. So we've got better communication as a result of practicing these kind of events and simulations. And some of the other things that have come out of those simulations are what we call call outs, right? So the nurse, in the midst of taking care of the patient, when the physician's in the room, the nurse says the patient's blood pressure is 90/60 and she's tachycardic to 130 beats per minute. The blood banking has been called and is now activating the massive transfusion according to your orders. And the other two things that have come out of doing simulations are what we call closed loop communication, and we do debriefs, right? So an example of a closed loop communication or callback is when the physician says, well, give her 0.2 milligrams of methogen IM, the nurse would then respond 0.2 milligrams of methogen IM given. So they close that loop of communication from the physician to the nurse. And then we do what are called debriefs after certain events. And we do this after, and this is probably as a result of doing debriefs during the simulations. And it's sort of a non-judgmental way of going back and looking at what we did well and what we could change to do better. That particular patient that I talked about walked out of the hospital 2.5 days after her cesarean delivery, after receiving 4 units of blood products, and then returned to see her OB provider within a week after delivery with no complications. A good ending to something that we had been practicing, again, and it's sort of hardwired into what we do on a daily basis.
Thank you, Dr. Hill. So this simulation course was provided to over 120 hospitals across Texas. What are some of the lessons learned or any challenges or pleasant surprises that you guys want to mention in regard to writing and scaling the course?
I think one of the things that was really interesting to see was how excited people were to be able to come and do the training. So it was one of those things where, everyone was motivated by, the opportunity to reduce maternal morbidity and mortality. Everyone was excited about the opportunity to implement the AIM bundles. It was just kind of that connection between here's the document and here's what this actually looks like. And to be honest, the other thing I was just pleasantly surprised with was how much people are already doing. And, it's always fun whenever we run these courses, we wind up running them learning as much as the people that are there, because people just have really brilliant ideas and solutions to issues at different size hospitals. And so that was really exciting. Other things I learned along the way were, the importance of a large organization that is committed to doing something like this. So the commitment of the Texas AIM team, really, and the organization, I just can't say enough about their organizational skills with regards to how they could put all of this stuff together. I think the other pleasant surprise, was finding out that this is possible. Like, it's possible to implement something like this in a state as big as Texas. And, it was really great to see how everyone could come together, and that this is something that, we may talk a lot about, but this is actually possible.
Thank you, Dr. Deering. So what's next for this program? Where do you see this evolving, and how do you see it maybe grow out of? Is there a possibility for that?
Yeah, I'll jump in on that. So right after we did this in person, it was about a week later that everything's shut down because of COVID. The pandemic has been a lot for everybody in so many different ways. It has pushed us to do things virtually, whether it's meetings or other things, and it's given us another opportunity with regards to this training. We took the Practicing for Patients program, which initially really was focused on postpartum hemorrhage, and we went back to the Patient Safety Council and said, we'd like to make this more broad. So we've made it, the instruction manual, a bit more agnostic to the actual obstetric emergency, and we're just starting with new bundles. So this year we have started with the hypertension bundle, and we have created the same thing: simulations, debriefing forms, video examples, training aids, everything for hypertensive emergencies in pregnancy. So severe range hypertension, eclamptic seizures, and we're implementing it again across Texas through the AIM program, but we're doing it virtually this time. So instead of having 5 different training sessions where we're getting everyone together in rooms and doing the training, we have the ability we have instructors who know how to run this course, and we have up to 4 hospitals for every 2 instructors. We're teaching them the material. They're going through, we're having them run the simulation. We're facilitating the debriefs and helping them through that. The great news is we're doing the same thing. We're just doing it virtually. And what that also means is that we have the opportunity to help do this on an even larger scale now. So instead of having to get everybody together to physically go places with all the travel, we've been talking with other states and collaboratives about doing exactly the same thing in a virtual manner, which, again, we didn't have that option before. So we're not happy about the pandemic, but we're excited about kind of where it's pushed us and made us go. And, we plan to every year, we're going to take a bundle that's come out through AIM, and we want to do the same thing. So we'll just build this entire library of programs and simulations that people can use. And once they've been trained, all they'll have to do is find the new one, and they can just keep going. One thing I want to encourage people to do is these resources are free. Practicing for Patients, they're on the website. Everyone can get to them. If there are people that are interested in the implementation part of it, you can do it without going to a course. You can do it. Everything is there. And if you have the people and the expertise, please, absolutely jump in, get this stuff started. But we also want to offer that, we're also open to talking with people, helping them through. Really what we want is we want people to be able to use this resource basically the best way possible so they can see the outcomes that we've been watching.
Thank you, Dr. Deering. And I think that's such a great words of encouragement for those who are interested in this. And knowing that you have done it and really push others to do the same. So thank you for sharing that.
Can I just make one last comment?
Sure, Dr. Hill.
I think the other thing that's critically important in being successful in implementing this simulation drills is to involve the administration leadership early on, and then find multiple champions who are passionate about the program, and then scheduling your simulations is to make sure the participants are part of a multidisciplinary team, that you've got blood bank, you've got NICU, you've got pharmacy, et cetera. And then allot time and coordinate schedules, and most importantly, be flexible in coordinating these simulations. I think those are some of the key points that I've learned throughout our hospital implementation.
Those are great reminders that we all need to work together and make sure all of the team's voices are heard when doing this work. Chris, did you have any final remarks before we close out today?
Well, I just want to thank and recognize everyone who's worked on this these teams. I especially want to thank AHA for your leadership role in helping really start this conversation and continue this conversation. We know that more than 50% of maternal deaths could have been prevented, and it's up to us as healthcare providers to continue this journey. Also, extremely appreciative of being a part of a state that's taking this seriously, as well as part of a healthcare system like Christus Health, where we're really taking maternal mortality and morbidity and improving our patient care and our outcomes seriously as a system. It's been exciting to be part of this journey, to collaborate with so many amazing clinicians and nurses, associates. As Dr. Deering described, people have been just overwhelmingly welcoming to this teaching and this training. They're hungry for it. They always, as being a care provider, want to do the right things. And so this teaching and training and practicing together has just led to incredible outcomes. People feel great when they have great care, and just the appreciation. Birth is the number one admission to hospitals in this country, and the United States needs to be leading in outcomes, not trailing in the world. So just thank you again for your time and listening to us as we share our stories. We're happy to share with anyone else as well, and just excited to be part of this conversation.
Thank you, Chris, Dr. Deering, and Dr. Hill for sharing all the great work you're doing to improve maternal and birth outcomes for your served population. This is another example of how evaluating your hospital data and success and processes and addressing gaps in care can lead to better outcomes for mothers and families. For more podcasts, education, and additional tools and resources to improve outcomes for mothers and babies, please visit AHA's Maternal and Child Health webpage. Thank you for listening.